Hi, everyone. I'm Heather Mannion, and I'm the Director of Clinical Operations here at PIRCHE. And it's our pleasure to introduce Dr. Kelley Hitchman, Associate Professor at the University of Texas in San Antonio and Section Chief and Director of the Histocompatibility and Immunogenetics Lab at University Health, where she holds the Flores Family Endowed Professorship. She serves on the boards of ASHI and the Texas Transplant Society, is the current vice chair of the OPTN Histocompatibility Committee, and co-hosts ASHI's podcast, Coffee and Compatibility. Dr. Hitchman is also an altruistic kidney donor and continues to be a champion for living donation. Please join us in welcoming Dr. Kelley Hitchman.
Thank you so much, Heather. Really appreciate it. And thank you so much to ASTS and for the folks at PIRCHE for this opportunity to share our experience as we seek to expand our toolkit for immunologic risk assessment. So let's dive in. Today, I'd like to give a little bit of mechanistic background for allorecognition, such that when we talk about immunocompatibility assessment strategies and tools that we may apply to these strategies, we kind of know all the confounding factors. It's a very complex immunologic system we're looking at, and of course, put some data behind it. So, of course, there are the classic three mechanisms for allorecognition. So, direct recognition is a circumstance in which a recipient's T cells is contacting a donor-specific antigen-presenting cell. So perhaps this was a passenger antigen-presenting cell that came over with the graft, and it has gotten itself into a secondary lymphoid tissue. And in this circumstance, the recipient's T cell can recognize differences in the donor's HLA or MHC molecule, which can lead to allorecognition and graft dysfunction following the activation of the recipient's immune system. Then there's also semi-direct recognition, which is a circumstance in which a recipient's own antigen presenting cell has acquired a donor's HLA molecule and presented it as its own. So again, in this context, the recipient T cell is recognizing a peptide MHC complex that includes an MHC molecule that is foreign from the donor, and the same consequences are possible. But really what I want to highlight today that's most pertinent to a lot of the talk that I'm going to give is indirect allorecognition. This is more of what we consider a classical type of recognition. Segments of donor have been taken in by a recipient antigen presenting cell, processed, and then inserted into a self MHC or HLA molecule and presented on a recipient antigen presenting cell to a recipient T cell. What's really important to consider is that while indirect recognition can lead to CD4 or CD8 T cell activation and signaling, this is really important mechanism for CD4 T cells to be activated by this indirect recognition, and then to further down activate and aid in differentiation of B cells, which then of course can differentiate into plasma cells and contribute to antibody-mediated rejection in our kidney patients and our lung patients and our heart patients and all our transplant patients. So it's really important, I think, to think about the fact that our T cell repertoire is so diverse. So during development, immature T cells are carefully selected in the thymus to try to limit to less self-reactive and more self-tolerant cells that will mature and enter the circulation. Each mature T cell can display thousands of copies of a unique T cell receptor. Most of those, of course, are made from alpha and beta chains, but these T cell receptors recognize antigens presented as peptides by HLA or MHC molecules on the surface of antigen-presenting or infected cells. And this follows some kind of specific rules based on preferred detection of amino acid sequences in those peptides that are being bound. I think the key part to remember is that while the potential diversity of T cell receptors is extremely high as 10 to the 15, 10 to the 20, the actual number of those T cell receptors found in the human blood is much lower, tens of millions of unique T cell receptors for naive T cells and even fewer memory T cells. So because the number of possible antigens that could be encountered in the span of a lifetime exceeds the number of T cell clones present, we know that T cell receptors can cross-react. In other words, a single T cell receptor can recognize multiple different peptides. And on the other side of the signaling communication, it's very important to recognize and consider that there is a diversity of peptides that can be accommodated by HLA and MHC molecules that can be presented to a diversity of T cell receptors for recognition. And so what you see here is kind of a conventional recognition where the T cell is contacting the HLA or MHC molecule and recognizing the peptide, but also the HLA molecule. And allo recognition works similarly, but it is of utmost importance in that guise that the HLA molecule itself might be the cause of recognition and activation in an allo recognition context, even though it looks a lot like classical recognition. So basically, allo recognition has the impact of allowing for a kind of mirror of conventional CD4 T cell responses. These CD4 T cell responses, once activated by peptide or by foreign HLA or MHC, can help B cells. Those B cells can class switch and differentiate into plasma cells and lead to antibody-mediated rejection. In addition to that, alloantigens from migrating donor dendritic cells or extracellular graft vesicles can be captured and can also signal with B cells to interact with B cells. So once indirect allorecognition takes place, those T cells will migrate to the B cell zones, and eventually antibody production will ensue. And that's what we all want to prevent. So I think from the MHC or HLA side, it's really, really important to understand how peptides come to be accommodated by those HLA molecules. It's not the case that an HLA molecule can only accommodate a single type of peptide. The diversity is greater than that. So in the case of indirect recognition, where we're really interested in T cell activation that leads to a broader immune response, we really want to prevent AMR. In those circumstances, for CD4 T cell activation, we're talking about signaling through MHC class 2 or HLA class 2 molecules. So you can see the schematic there, and kind of toward the bottom center is what a peptide looks like when it anchors in an MHC class 2 molecule. And these MHC molecules, these HLA molecules, can accommodate different peptides. The similarity in those peptides is in what those anchor residues are. So in this circumstance, perhaps the first residue in different peptides can be accommodated by the same HLA molecule, but maybe they all need to be hydrophobic in the first anchor residue position, negatively charged in a different position, basic in a different position, and hydrophobic in another position. HLA class 2 accommodation of peptides is unique in that the peptides can be a little bit longer. They can kind of lop out the edges of the molecule. But HLA molecules can hold a diversity of peptides, and T cell receptors can cross-react with a diversity of peptides. And that's really important to realize. And it even gets so complicated that T cell receptors binding to different types of peptides it is differential. It has differential reactivity rates, differential affinity rates. So all of these little details that seem so distant to our clinical view are so key for what we take into consideration in immunologic risk assessment between a patient and a donor. Um, and that has evolved a lot over the years. Of course, our goal in compatibility assessment is to prevent graft rejection, specifically hyperacute rejection, but also we want these grafts to last as long as possible. And our tools for accomplishing that goal have evolved quite a lot over the ensuing years, from lymphocytotoxic testing to consideration of kind of broader serologic reactivities, cross-reactive epitope groups, and then the genesis of this wonderful tool from Paul Terasaki, these Terasaki trays, where we could get a little bit closer to more broad but specific detection of antibodies against an array of donor targets. And then the advent of flow cytometric cross-matching for increased sensitivity and increased speed with donor-specific and patient serum immune testing. And then the multiplex anti-HLA antibody detection systems like Luminex, and of course, more flow cytometry panels. And then the advent of putting all of those tools together, the HLA typing and the very sensitive and specific anti-HLA antibody identification testing to perform virtual cross-matching. Realizing that at the same time, not all pairs might have the same potential or capacity to produce an immune response, even when you know the patient and donor typing and the patient antibody load, even longitudinally over a period of time. So it would be great if we could find an HLA identical donor for all of our solid organ transplant patients. But that is a tall order, especially considering that in the modern era, HLA labs are typing for a full set of HLA loci, ABC, DRB1, DRB345, DQ heterodimers, and DP heterodimers. Unless you have a sibling, in which about 25% of siblings would be predicted to be HLA identical, this can be a very tall order. And we know from historic studies that even HLA identical pairings can have rejection for other reasons. So in the modern era, lack of HLA match is not seen as a contraindication to transplant. In transplantation, even across certain levels of preformed anti-HLA antibody can be successful with good immunosuppressive management. So we allow for HLA mismatch. But this also leads to more blanket or more broadly applies non-customized immunosuppression protocols. And then there are new ideas coming into the risk assessment space, looking at structural characteristics of HLA molecules to try to better define similarities and differences between patients and donors that could lead to increased or decreased incidence of rejection down the road. But there are so many options. There's a more macro epitope level. There's a more specific eplet level. There's an even more nuanced amino acid level. And then, of course, there are lots of people asking the question, even if there are structural mismatches between a patient and donor, are they really immunogenic? So none of these approaches that I've noted here are really measuring the true likelihood or immunologic capacity of a specific recipient immune system to actually present specific donor alloantigen, allopeptide, for the propagation of an immune response leading to rejection. We're defining differences between the patients with regard to their histocompatibility. We are defining the presence or absence of antibodies against the donor, but we are not defining how immunogenic or the potential for those to lead to an actual immune response in a specific pair with the currently applied methods. So here I give you a very generalized view of what a virtual cross-match entails at most centers. You look at the donor and recipient typing, and I'll say that this pair is really important because I will use this pair throughout a lot of examples in my talk today. This is a living donor pair, and you might be able to tell that because we have high resolution HLA typing across all common HLA class 1 and 2 loci applied in transplantation here. So we can certainly compare the typing of these two individuals and couple that with an amalgamation of longitudinal anti-HLA antibody identification testing, which hopefully also includes testing for spurious potential and specificity. And then we take all that data together and we put together a center-specific risk consideration. Is your center a larger center that incurs some more risk? Is your center a smaller center that perhaps is more conservative and doesn't incur very much risk? Often these consultations are customized to meet the level of risk that a given center is willing to incur. And so we identify the DSA against the donor, and we present that in a context of recommendation or lack of recommendation for risk, or a risk stratification from an immunologic histocompatibility specific perspective. But there are certainly people who are now using some of these structural histocompatibility tools to add to their immunologic risk assessments. One of those tools in which you can define Eplet mismatch load structural similarities or differences between a donor and patient, and here I use the same donor and patient from the former example, is the Eplet registry, which is a great tool that now has an Eplet mismatch calculator. You type in the HLA typing of the donor or immunizer and the patient, and the system will tell you what HLA-specific Eplet mismatches are present for each locus, and the total of those Eplet mismatches. And if you look in more granular detail, you can see specifically which alleles in the donor or immunizer are contributing the number of mismatched eplets. And these eplets in brackets are antibody verified eplets, meaning they have been shown to have the potential to be immunogenic. So this is all very interesting and useful information. But it's certainly not the only system that you can use to characterize Eplet mismatch load. A more classic system that was developed by René Duquesnoy that many people have published on and used for a long period of time is HLA Matchmaker. And it's a very similar type of system. You input the patient and donor typing. High resolution is, of course, very helpful for this. And you get back a number of eplets for, in this case, each class. And you can look and see which immunizer HLA types are contributing which eplet mismatches. And it'll also tell you the number of total eplets per class and antibody verified eplets present. Interestingly, you might notice this is the same pair that I've used throughout these examples. The number of eplets that are being returned by the Eplet registry and by HLA Matchmaker in this case are different. You would think maybe they would be the same, but that's not necessarily true. And that can be because of a variety of factors. You know, are duplicitous eplets counted repetitiously? Are these two systems updated for eplet changes at the same cadence? A lot of things can feed into that, but the answers are not necessarily exactly the same. So when we think about HLA-based histocompatibility, we have to think about the way that we think about HLA match grade. When you're looking at deceased donors in the middle of the night, that is usually low resolution typing. There are several progressive laboratories in the country that are applying high resolution typing to deceased donors, and that's outstanding. We need more of that. But we're not often looking at high resolution typing for every case we assess. We don't have standard virtual cross-match mechanisms. These are usually center specific. And the application of structural mismatch scoring, be it epitopes, eplets, amino acids, is differentially and not very often applied in these cases. And again, none of these schemes that I mentioned above really measure the likelihood or immunologic capacity of a specific recipient to actually mount an immune response against specific donor peptides in the guise of indirect allo recognition and propagate an immune response. So this might lead to several clinical questions that you'll come up not infrequently. My patient has had a prior transplant, but we didn't detect any DSA post-transplant. Now they're up for retransplant. Should I be worried about the prior donor HLA mismatches since they didn't produce antibodies to them? If so, how much? Should I mark them as unacceptable, or should I, just monitor them more frequently? What if the antibodies were there, but we just didn't see them because we weren't monitoring during the time period that they were produced? What if your patient had a prior solid organ transplant and rejected subsequent to the development of significant anti-HLA antibodies? How does this impact future offers once your patient is relisted or has a living donor? What if there's the really complex situation where your patient had a liver transplant and now they're up for a safety net, a kidney, a heart, a lung, and that liver is in there absorbing or dealing with the antibodies specific to the liver? How does that impact your patient in the present? The liver maybe desensitized the patient in that moment. Maybe some of those antibodies recurred, some of them didn't. What does all of that mean? And maybe a question that we think about all the time is, can I minimize my patient's immunosuppression in the context of this specific donor? All of these are really important questions. So one tool that is somewhat recent is from PIRCHE, and PIRCHE stands for Predicted Indirectly Recognizable HLA Epitopes. The PIRCHE program today offers a lot of modules with which to add to a risk assessment. And when we were reading some of the literature and some of the people applying some of these PIRCHE tools, and there are many more tools in existence today than there were even a few years ago, this was very interesting to us for a variety of reasons, and I'll kind of show you why that is. So let's first talk about one of the first arms of the PIRCHE tools that you can look at, and that is T-cell allo recognition. The T-cell tool, which was called PIRCHE-2, but is now going to be called PIRCHE-T2, is basically a calculation of donor HLA peptides that may be accommodated in a recipient MHC2 or HLA class 2 molecule and presented to T cells. And so you kind of see here the schematic. You have a mismatched HLA antigen. Peptides can be generated from that donor HLA mismatched antigen, and only some of those peptides will be able to be accommodated by the patient's MHC. And we can calculate that in this system and assign a load or a score to that. So again, the detail that we're looking at here is donor-specific HLA peptides that could be accommodated by the recipient's HLA molecules and presented to T cells for allo recognition and potential graft dysfunction. Now, a while back, there was also a B cell component added to the PIRCHE view because there is a lot of data about the utility of looking at structural HLA mismatches between a patient and donor with regards to future antibody recognition. This was characterized by looking at the surface of the HLA molecule, what would be available potentially for antibody binding. And in this guise, they basically have augmented characterized HLA molecule crystal structures with predicted protein structures, in addition to predictive residue protrusion. And you might have heard of something called an Eplet score. This is different than that. So it's kind of telling you, it's characterizing the molecule's surface structure, but also saying what characteristics of the surface have ideal protrusion. So this used to be called a snow score, and now it's called a PIRCHE-B score. These are donor-specific amino acid mismatches with high protein-specific surface area and high protein-specific local protrusion rank. So these are donor HLA molecule surface characteristics that might be very attractive for recipient antibody binding. And so what does that look like? That's a lot to take in. So this is, again, that same patient and donor pair that I used in my prior examples, put into the PIRCHE ramp module. And this allows me to kind of use the PIRCHE T2 and the PIRCHE-B scores to kind of see what my immunologic risk is in some more granular ways. So first, it looks at the donor and it highlights in red the donor HLA mismatches, and it tells me right off the bat how many donor peptides could be presented by my recipient's HLA class 2 molecules, and also what the B cell consideration, the surface mismatch looks like. And you can see that at a macro view, but also at a locus specific view in number and in color coding. Of course, the more aggressive the color density, the more potential mismatches for recognition, for presentation and recognition are there. And that's presented for the T2 score and the B score. And here, if we dive a little bit deeper, again, this is the same patient and donor. It will present to you in the ramp molecule. So you do say, when you're using the PIRCHE algorithm, you can look at specific populations of NMDP databases as donor reference databases. So you're not just comparing your patient to the donor in question. You can also say, okay, this is what this donor looks like, but where does this donor fall in the risk scheme for an NMDP population? And that can be a total NMDP population, considering all common large ethnic backgrounds, or you can specify, a Hispanic NMDP cohort, a European NMDP cohort, an African American NMDP cohort, or an Asian Pacific Island NMDP cohort. So when I look at a total NMDP cohort for this pairing, it's telling me that the patient's median T2 score is 89 for a total NMDP population, and 18 with the B score for an NMDP population. And so this donor that's proposed for this patient is better than this patient's median risk for presentation. And then you see the rank there as well. The rank is meant to say the percentage of virtual donors that would lead to a lower score. So in other words, only 18% of differential donors from an NMDP donor pool would be better than this donor with regard to the PIRCHE score, and 51% might be better from a B cell score. And you can see that visually too. So you have a lot of different ways that you can look at the data. The squares here are meant to put up the data comparing SNO and PIRCHE scores, or the B score and the T2 score, to tell you about the donor proposed, but also a broader population. In other words, I've got this donor. What is the risk associated with this donor? But also, could I do better? or is this a pretty great option for my patient? So that is what is meant to kind of be represented here. So the size of the square tells you about the frequency of this particular risk category. So this donor lays in the most frequent risk category for this patient. You might be able to do better, but the frequency of those lower risk donors for a T2 score is much less. And the frequency for worse is also a little bit less. So you're kind of finding a pretty good donor in this case. Not perfect, but pretty good. And you can also input information, and I'll show more information about this in a little bit, about previous immunizers can be considered here. And also, if you want to know or assign unacceptable antigens to your patient and see how that changes the risk assessment, you can also do that. There are, like I said, a lot of ways to look at the data in these modules for some added comfort with the risk assessment. So here we're looking at kind of a combinatorial graph for our patient and donor pairing that show the PIRCHE score right up against the SNO score, which is in light green, and then the frequency of those different alleles in your pool. And this is based on the most commonly tested for alleles or antigens in current single antigen testing modalities. And if you want to, if you see some of this data and you want to make it more actionable, you say, well, I kind of want to avoid for my patient the HLA donor alleles that have the highest probability of being presented by my patient's class 2 molecules to mount an immune response. You can actually tell the system to highlight those for you and list them as unacceptable and see what the CPRA calculation would be if you do that, which is kind of a nice feature that allows you to customize and balance risk for the patient based on this data. So this data is made to be actionable. So what about these contexts where in our previous example, that patient had never undergone a transplant before? Things get much more complicated often when the patient is a prior transplant recipient. And we have had this circumstance happen to us. And here's a great complicated example of that. Here's a 33-year-old female retransplant candidate. She's up for a kidney, and her 36-year-old half-sister has come forward to potentially be a living donor for a kidney for her. And that's wonderful. But this patient has had 2 prior transplant events. One of them was a combined intestine, liver, pancreas, and the other was a deceased donor kidney. And maybe not surprisingly, she is sensitized following those events, not as highly sensitized as one might think. She's been very compliant with her immunosuppression, but she certainly is sensitized to some HLA and mostly class 2. So if, excuse me, if we just look directly, oh, excuse me. So if we just look directly at the patient compared to her half sister, this is not a bad pairing. The sister, there's only a 22% chance or a 20% chance by T2 and B score, respectively, that we would find a better donor compatibility when just putting the patient against the donor directly with regards to what donor peptides could be presented in the context of the recipient's DR molecules. But what about the previous immunizers? There are lots of previous immunizers, and what about unacceptable antigens? So we don't have to ignore those in the context of these risk assessments. We can add those into the risk assessment. So to this, I can add the prior kidney donor and the prior intestine, liver, panc donor and see how those donors looked compared to the proposed donor. And actually, the prior kidney donor was a pretty good potential for this patient. And this half sister is very similar in risk to that prior kidney donor. I'd also like to point out that for these prior transplants, they were performed in a time where only low resolution typing was available for the patient's prior transplants. And I imputed that data for some of the analysis you'll see down the road, but you don't have to do that. PIRCHE can accommodate both low resolution and high resolution data for these risk assessments. So digging into the nitty gritty, I can consider the patient's prior immunizers by telling the system, like, hey, this patient has been exposed to these specific HLA types that are noted in this yellowy orange color before. So I'm noting these antigens as previous immunizers. And the system is then going to reflect that added risk in a recalculation of the PIRCHE T2 score and the PIRCHE-B score to say, related to those previous immunizers, these other HLA antigens are similar to those. So your patient could have memory responses to these other things in this exact frequency calculation. So this is really good at seeing how a potential memory response might ensue that might impact a future offer. And you can look at it by locus. Here I have class 1, A, B, and C. And then also class 2, DR and DQ. You might notice that the RAMP module that I'm using here right now really considers ABC, DR beta 1, and DQ beta 1, but it's my understanding that additional loci are being worked on to be incorporated into these views as well. So this is all very intriguing, but I, like you, might say, well, this is fancy, it's scientifically intriguing, but what does the data say? And so we got interested in looking at these PIRCHE modules in our patients when we saw this data that was originally produced out of the NYU group, and Massimo Mangiola produced this data with his collaborators. And they were looking at a smaller cohort of pediatric heart recipients. And they were able to develop a combinatorial analysis in which, in addition to a standard virtual cross-match, they were looking to see, does adding in an Eplet mismatch calculation threshold and or a PIRCHE T cell calculation threshold or score help me determine better risk thresholds for this cohort of patients. And they were actually able to develop cut points. And in those cut points, they found that a combinatorial approach was the most useful. So they suggested potential cut points for class 1, HLA-DR and HLA-DQ, Eplet mismatch loads, and PIRCHE T2 scores, in which they saw higher instances of developing de novo DSA and antibody-mediated rejection if those cut points were exceeded. So this was very intriguing, especially thinking that if we could differentially risk categorize these patients, maybe in emergent cases, we wouldn't use that information to say yes or no to a transplant, but could we personalize immunosuppression in that way? So we did an early study, a very simplistic study in which we wanted to see, are those cut points universal? Or do you really need to, validate this differently for different patient populations? And what do we see when we apply those types of cut points and that type of approach? So we took a pediatric kidney cohort at our center. This was presented at ATC in 2024. We had a cohort of about 117 pediatric patients. And we wanted to limit this to patients in which we did have high resolution typing data. 63 of those pairs met our inclusion criteria. So we broke the patients down into those that developed de novo DSA post-transplant and those that didn't. What class were those DSA produced against? and then looked retrospectively at their Eplet mismatch loads using Matchmaker and at their T2 scores using PIRCHE, which I will say the algorithm has updated since then. So the algorithm is more nuanced now than it was when we were doing our study in 2024 even. We did not find, using those same cut points applied by Massimo Mangiola and their colleagues, we did not find the same significance with ABMR or graft survival, but we did find that PIRCHE-T2 uniquely was predictive of DQ mismatches between patients and donors, leading to formation of anti-HLA DQ donor-specific antibodies. So that was intriguing. So it told us a couple of things. This could potentially have some clinical utility in our patients, and we do need to investigate this further to find where the cut points and the clinical utilities are for different patient categories and different utilities in our patient population, which here in South Central Texas is somewhat unique. And there's a great paper out in Frontiers in Immunology this year, which looked at a large kidney transplant cohort. This is SRTR data, so this is from the US OPTN, in which they looked at the utility of different risk stratification protocols applied to an extremely large cohort. In all, it was a little over 400,000 matched pairs. And they found that when you look at histocompatibility scores using simple ABDR mismatch, so low resolution mismatch scoring, PIRCHE-T2 scores, version 3 and version 4, that the distribution of that data is very similar. Now, the frequency and the scores you get out of that data are very different, but the shape of that data is all very similar, very interesting. And then when you put that into Cox regression models and put it up against some histocompatibility data and some clinical data, what you see is that risk scoring by the newest iteration of PIRCHE-T2 was the most effective univariate model for predicting graft survival. And then if you combined that with other histocompatibility considerations, that was even more impactful. So a combinatorial approach is really useful. And then when you combine that with clinical factors such as ethnicity, immunosuppression, age, whether or not the donor was living or deceased, CMV status, etc., adding in these histocompatibility risk stratifications was the most indicative in these models of being suggestive of immune risk and graft survival. And this is certainly not a one-off instance. What I'm about to share with you is a series of data that was presented at this year's World Transplant Congress. So certainly going to thank the authors for giving me permission. We did chat and to present to you this data that they gave. And I should preface this by saying that these were presented at World Transplant Congress and are not yet published. So thanks to the authors for letting me share that. This first study that was presented at WTC this year looked at PIRCHE-T2 scores and their ability to assess a combined predictive power with donor reactive T cell frequency. And they analyzed this in regards to formation of acute rejection in kidney transplant patients. And so this was interesting. So the PIRCHE-T2 scores did correlate with the number of HLA mismatches between donor and patient, and did have a linear type of correlation with the donor reactive T cell frequency in their cohort. And I think most importantly, in this figure here, they showed that PIRCHE-T2 scores are associated with the occurrence of post-transplant abnormal biopsies, similar to their generated frequency of CD8 T cell reactivity found in blood and urine. And then there was another group, not to be totally kidney centric. This is a group out of Mayo Jacksonville that wanted to assess the relationship between the level of molecular mismatching and lung allograft dysfunction. So in this study, they had a cohort of 119 lung transplant recipients transplanted at the Mayo Clinic between 2016 and 2019. And they were looking at the instance of antibody-mediated rejection, chronic lung allograft dysfunction, and patient survival with a median follow-up period of about 62 months. And in this cohort, they used the PIRCHE-T2 and the PIRCHE-B scores, and both of those scores were significant predictors in some contexts of AMR, CLAD, and that was independent from induction, gender, BMI, and lung allocation score. And the PIRCHE-B score in particular correlated in this study with overall survival. So they thought this was very helpful and wanted to use this data to help identify pre-transplant candidates at higher risk of immune-mediated lung allograft dysfunction. And then there's quite a lovely study by James Lan and John Gill and Steve Woodall that aimed to evaluate the association of T cell epitope mismatch, these PIRCHE-T2 scores, with rejection among the ASTS corticosteroid withdrawal trial participants. So they did a lot of analyses of this cohort and found a cut point, a T2 threshold of 50. They did this by iterating discrete thresholds and fitting a logistic regression on this training data set to try to predict rejection amongst the testing data. So they underwent quite a bit of analysis for this. And what they found was that overall, patients with PIRCHE-T2 at that cut point of greater than 50 did have a higher instance of acute rejection. And patients with low PIRCHE-T2 scores, the instance of rejection was comparable with patients that were treated with corticosteroid withdrawal versus steroid maintenance. So this is really specific to different immunosuppression schemes. And interestingly, patients with low PIRCHE-T2 scores, their instance of rejection was 10%, irrespective of steroid use. So the suggestion in this study is that you could risk stratify patients to use different steroid withdrawal techniques. So this is a really interesting study cohort and garnered a lot of interest at World Transplant Congress as well. So I hope I've given you some food for thought today. I know that the data is very compelling in a way that wants us to do more study. And we're involved right now in several collaborative studies and center-specific studies to try to see what these tools might mean for our patients and in what ways we can possibly incorporate them into risk stratification for our patient populations. So with that, I will stop and entertain questions. And again, want to give special thanks to the folks at PIRCHE and for ASTS, and absolutely to the investigators that allowed me to present their WTC data for inclusion in this presentation.
Thank you, Kelly. So it looks like we have a couple questions. One is how is the PIRCHE algorithm considered the fact that, oh, I'm sorry, there's different eplets may have different immunogenicity to generate the score. And I think, I mean, I think I can answer this. We're still working on immunogenicity. Yeah, because I know that you've even asked, I think all HLA lab directors ask that
Yes.
question.
Yeah, absolutely. Yeah, absolutely. So we would like to take the data that we generate and look at different studies. There's Anat Tambor's uh, one mismatch, or sorry, two mismatch, one DSA model. So we would love to see, do those trends that she's seeing in her immunogenicity studies overlap with some of this? These are all fantastic questions that we would like to explore. I want to clarify that in my presentation, when I say that you're giving another immune risk component, what you're really saying is, rather than just saying these differences exist, you're adding on, this is the likelihood that they could actually be presented for immune recognition, which is an important, I feel, potential piece of information additional to the type of risk assessment that we're currently doing. So it is giving a new idea of immunogenicity, but not specifically addressing the actual execution of immunogenicity.
Right. There's a question. So, what is the ethnic diversity for the groups that you presented and established cutoffs? And this is from Mary Philogene, Dr.
Oh,
Philogene.
that's a great question. So I will say at our center, we have not established cutoffs. Of course, our center specific studies that I presented data from are about 60% Hispanic, and the majority, maybe 35% Euro-Caucasian, and the remainder would be mixture of African American, Asian Pacific Islander. So our cohort is very skewed, which I think is very important for collaborative study. And we've joined with other centers for collaborative study to lend more Hispanic data to those studies. But also, when you're considering using these tools in a center-specific context, should we use the NMDP comparisons as a whole for our patients in every context? Should we use the Hispanic specific NMDP, the Euro-Caucasian specific NMDP? Very important. Massimo's study is out of New York. So that cohort, while small, it's pediatric heart, would have a certain type of diversity. The study with Lan and Woodall and group is Canadian. So there's probably, but it's also an Astellas study. So that was more balanced, but I think from my recollection might skew more Euro-Caucasian. So we do need more large collaborative studies that address ethnicity. This is a great point and a wonderful question.
It looks like there's a question that says, how can clinicians use these tools if their centers lack number statistical power for validating the cutoffs?
Say one more time, I'm sorry.
So, how can clinicians use these tools if their centers lack the numbers or statistical power for validating the cutoffs, their own cutoffs?
Yeah, so as far as power calculations, I think collaboration is king. And while your center might be unique, it's probably not so unique that you could not find a collaborative center to join with. And if you want to investigate these tools, a center might be absolutely happy to collaborate with you to find if they also want to use these tools. So I agree that we shouldn't do these studies in a power calculation vacuum. Let's collaborate. It's a wonderful point, and I'm so glad people are thinking in that way to not have biased data.
How did you incorporate this into your own program's virtual cross match?
So I will say that we are not using this in my program's virtual cross-match to date as a blanket prescription. Now, in very complicated cases, if I'm really on the fence due to potential anamnestic responses, I have looked at pairs with the TMEM function so that I can educate myself and really say, especially in a living donor context where you might have other opportunities down the road and time for planning. Is this really a good offer that it seems, or is there a potential anamnestic issue here that I need to think about? I have found this tool also to be useful when we have children and they do like a donor call for living donors, and 100 donors come forward and none of them are biologically related. You might find lots of donors that are a good antibody compatibility in that context. They might even be a good Eplet mismatch load, um, pairing in that context. But if you want to select, if you have options and you want to select the very most compatible, why not consider this too? I think, and we haven't applied this certainly, but we are thinking about it. How might this change our immunosuppression strategy for our different patient cohorts? That's an area of study for us, but we are not routinely using this in our virtual cross matching yet. We have more data to collect.
It looks like there's a question. So, what was the post-transplant period that you considered to make the correlation between PIRCHE and the production of the de novo DSA?
Mm. So for our kidney transplant, our very small kidney transplant study, we had data on those patients, on some of those patients going back to 2013. So for some patients, we have over a decade of antibody data to compare that to. And then for some patients, because that study went clear through 2023, for some patients, we had a year of follow-up, right? So we need more depth in long-term outcomes. And I really, really encourage you to read the Frontiers in Immunology 2025 paper, because it addresses that exact point. I was very surprised at the SRTR view of how histocompatibility risk assessment contributes to the acute picture versus the long-term picture. And I think in that study, it's a little more than 8 years post-transplant outcomes. It's actually very much more impactful for long-term outcomes than it might be in short-term outcomes. So we intend to look at that, but we need to do more longitudinal studies and hopefully some prospective studies. Retrospective studies are great for long-term follow-up, but we need unbiased prospective trial-like studies as well.
And it looks like there's a question. So, has the use of the new tool improved the placement of organs, for example, deceased organ non-use? And I think this is, I mean, we could both answer this that we don't know, no, but there's potential. I think that it could go in that direction as more programs use it. I don't know what the utility, how much are using it right now for deceased organ donation. What are your thoughts on that?
Yeah, that's a great question. I will say, and I can only think of a couple times, less than a handful of times, where I've been doing a virtual cross match, and based on pretty standardized data utility, I've been on the fence for a given patient and have been trying to determine together, let's say it's a kidney, because that's usually the context in which I've come up against this, trying to determine with the nephrologist on call at whatever o'clock in the morning it is or at night that it is this a patient where we want to push our immunologic risk boundaries? Do we think we could do better? Is there a piece of information about the patient, be it clinical or histocompatibility, that pushes us to one side of the fence or the other? I think this type of data has the potential to really help in those types of situations. Is this really worth the risk in this moment of a deceased donor context where you really have to make a pretty quick decision? Um, because you have those donor frequencies to compare to. I find that very helpful in those I'm on the fence types of decisions. And just sharing that information with our nephrologist and having a discussion has been helpful in a couple instances for us.
Well, I want to thank you so much, Dr. Hitchman. This has been a wonderful presentation. And I think we are at time, but again, thank you so much. And thank you for everybody for attending.